starting our comprehensive ophthalmology session, and Dr. Rakesh Shakya, Dr. Kishori Lal Gupta, Dr. Sandeep Kumar Shah, and Dr. Bharat Mehta are invited on the stage. As we are running short of time and many of us have to catch the flight, so I request Dr. Mahesh Somani to please begin with his first talk as NABH related preparation of NABH with advantage of it.
It's okay.
Hello.
Dr. Tanya Mohan. I will just check who are all having the.
Yeah, I think he will just check. So, where is Bharat Mehta? He's a moderator. No, I can't see him. Bharat Mehta is not here. Tanya is there. Mahesh Somani is there. I think he's Dr. Malhotra, the one who's sitting here. The guy with the black shirt. बेटा कौन आया है साईं? Sir, can you start please? मैंने बुला दिया, आपने सुना नहीं. ठीक है. So our speaker is Dr. Mahesh Somani, and he will be speaking on NABH related preparation of NABH with advantage of it.
Dear friends, first of all, I'm thankful to my Dr. Namta Sharma and AIOCMTC Scientific Committee to give me opportunity to speak on this topic, which is very burning, and new things are coming in now. Advantage of NABH accreditation and preparing for NABH accreditation. The benefits for the patient. The patients are the biggest beneficiary among all stakeholders. Accreditation results in the high quality of care and patient safety. The patient are serviced by credentialed medical staff. Rights of patient are respected and protected. The benefit for the organization. The healthcare organization stimulates continuous improvement. It enables the organization demonstrating the commitment to quality care and patient safety by best clinical outcome. It raises community confidence in the service provided by healthcare organizations as service provider by credentials medical staff. It provides opportunity to the healthcare units to benchmark with the best. And accreditation status provide marketing advantage in a competitive healthcare. The SEO standard having been certified by ISQA, given international recognition, which will also help to promote medical tourism. And finally, it provides an objective system and implemented by insurance and other third parties. For the staff, it is satisfied lot as it provides for continuous learning, good working environment and leadership. Efficient and competence of the staff also gets improved in an accreditation process, and it improves overall professional development, knowledge, competency in systemic way with defined ownership, accountability of all the staff, including medical and paramedical staff. Benefits to paying and regulatory bodies. The accreditation provides an objective system of implemented by insurance and other third parties. It assesses to reliable and certified information on facilities, infrastructure. You become a brand in many non-accredited hospitals. Documentation becoming up to the mark, which helps legal issues. We hire qualified staff, and training is continuous process. Among 100 high hospitals in the city, if 20 are accredited, so it helps in growth. We have SOPs and manuals, which is set pattern of working. Training on different issues is continuous process, so new staff learns from beginning. As a process, there is less stress as work is responsibility is transferred. There is continuous quality improvement. So, if you are starting a new hospital and willing to go for the NABH accreditation, so first thing is to have a perfect will to have it. And why you require to have accreditation? Some put up their own team to understand and implement standards, while others hire consultant to help them towards this. Preparation requires sufficient resources, proper planning, dedicated efforts on the part of organization, a journey with milestones to achieve, and unless the path and approach chosen is correct, milestone can become difficult. In a high hospital, full NABH accreditation, we have to apply in STO standards. For pre-entry, we have to apply in SSTO standards. And I setup are very small of many individuals, so pre-entry is possible to achieve. The first and most careful step to be taken towards the accreditation is to take a firm decision to go for it. Since the time money and efforts are involved in accreditation preparation can be substantially high for many SEOs, which is based upon a fairly good idea of resource and effort required, can help SEO, overcoming most of the roadblocks mentioned above. Initial steps in accreditation process is the baseline gap assessment of the SEO in comparison to accreditation requirement. In order to get a good idea about the present status and preparation required for accreditation, the baseline gap assessment should be focused upon those aspects that consume more time, money and effort for addressing. Following subsections provide an understanding on how to conduct a useful baseline gap assessment. For it, a proper team should be made. It is a teamwork. Start right from the baseline gap assessment. Since the exercise involves assessing different disciplines of the SEO, a relevant working team should be formed for this. The team should consist at least of one person who has significant knowledge and understanding of the accreditation requirements. He and she should be supported by members who are knowledgeable in field of civil engineering, legal requirement, human resource, biomedical equipments, and clinical care. List of standard objective elements can be used as a checklist to conduct the assessment. Physical facility includes all its engineering installations. Since they are difficult to modify and cost involved, assessment should carefully be identified in any specific relation to physical facility, but could be interpreted based upon the process-related requirements. Fulfilling HR requirements are also cost-intensive and time-consuming. Identify gaps related to HR requirements. HR needed to fulfill accreditation requirement with a special reference to staff, nursing, technical, required as per the bed strength and scope of the organization. And obtaining legal clearances, licenses, permits can be time-consuming tasks and at the time be extremely difficult. All regulatory requirement and processes necessary document for the same. Biomedical equipment gap analysis. Few important biomedical related points that should be checked during the assessment. The baseline gap assessment report, it gives in physical facility, legal requirements, HR and biomedical equipments. Each area should be assessed and gap of each area should be separately documented in the report. The gap can be highlighted as critical, semi-critical and non-critical from accreditation point of view. This report can become a checklist of major things to be done for accreditation preparation and make a checklist of important points to be covered in baseline assessment. It's time to assign responsibility for this work. While it requires everybody involvement in accreditation, somebody who is responsible for driving the effort is a decision thing to do. Should be made team leader. Although considering the amount and level of work involved in accreditation, the responsibility should be taken by one senior in the organization who has necessary authority. Then, accreditation coordinator is overall responsible for planning and preparation of the accreditation requirement across the organization. A senior person from the organization with requisite knowledge of accreditation and quality should be designated as accreditation co-coordinator. He and she also responsible for communicating with accreditation agency and handling external assessment. Depending upon the size of the hospital and baseline assessment, a team of working executives should be formed to work towards accreditation. This committee to play the advisory and monitoring role towards accreditation preparation. Department coordinator. For each department, one staff can be designated as coordinator and facilitator to undertake accreditation-related activities in their department. Before the preparation of accreditation work starts, the core team should assess their needs of obtaining necessary training with respect to accreditation. There are several training programs conducted by accreditation agency which can be attended by core team, including accreditation coordinator. If possible, SEO may invite expert to conduct an in-house training works on accreditation, which can be attended by larger number of staff, including department coordinator. Baseline gap assessment identify major time-consuming work required to be done. Initially, process gap assessment should be done at initial stage of preparation to identify the process and system that needs to be developed or modified. The process gap assessment can be done by core team in consultation with department coordinator. The standards and objective elements should be used as a checklist. The plan should be checked. If required, progress is being made within timeline for accreditation. The development in preparation should be reviewed periodically to match it with the plan, and whenever required, appropriate steps should be taken. Plan can be modified. There are two basic approaches, centralized and decentralized. The centralized approach, the primary responsibility with the core team and is done centrally. While department coordinator, other staffs are minimally involved, the policy, processes, documentation, and specs related are majority done by the core team for all department, which helps of input and information collected from the department. This approach better ensures compliance to plan and its timeline, and also provide uniformity in the system and processes across the SEO. Decentralized approach. In this responsibility of the undertaking, any completing work tasks are given to the departments, which core team only playing the role of supporting coordination. The approach builds better involvement of all staff and practically useful system, and processes can be created. The disadvantage, however, is difficulty in maintaining uniformity and a scheme timeline. An SEO can decide upon a mix of both. Activities that require high level of uniformity and critical direction can be handled centrally, while technically they require technical operational can be decentralized. For example, documentation can be done centrally after collecting relevant information from the department, while responsible for things like meeting regularity requirements can be given to department primarily. Some milestones can be created in between the journey to get a sense of progress and achievement. This can be done by phasing out the preparations plan with each phase representing milestone. Documentation, training, internal audit. This phase is directly to check whether or not the document system have been effectively implemented. Each department should be audited based upon relevant checklist. The exercise may be repeated if required. And second, accreditation phase. In this phase, activity related to external assessment and addressing the non-conformity are measured handled. This is the final phase as after its successful completion, it is granted to the STU. Key to success preparation. The success of accreditation preparation majority depends by whether or not STU got accredited. Dedicated and motivated core team. Core team plays the major and important role in accreditation preparation. Hence, having dedicated team for the purpose is key to success. Involvement of staff. Implementation of accreditation requirement is the ultimate check, which cannot happen without sufficient involvement of the staff and supervisors. Success of accreditation preparation is majorly determined by the whether or not SEO get accredited. Continuity of efforts, sustaining efforts till the end, what can the result? Correct understanding of the accreditation requirement and how to address team is another key to success preparation. Thus, having an expert of the subject in core team or advisor makes it more likely to resume its success management support. Keeping accreditation as a priority and having necessary cooperations from management is essential. Thank you.
Thank you, sir. Compiling such a huge topic of NABH into just 8 minutes talk. With your vast experience for the ophthalmologist, what do you suggest? Like how to go ahead with NABH, like if somebody wants to start afresh, is it entry level? It is different from the multi-speciality hospital. What should be the timeline, like normally an ophthalmologist will get into NABH?
Yeah.
And what will be the approximate cost incurred on this?
The cost depends one on the physical requirement. Whatever you're making from that time, if you plan the things and modify your plan accordingly, because mainly checking is at the OT level, the movements in OT, the 3 get entry for the patient, the movement of doctor inside and coming out, and movement of the spliced and coming out, spliced from other 2 different ways. So that is modified during the time of preparation of the hospital. That will be very good helpful. The second thing requirement is the legal formalities that you have to do as such, and which are increasing always. Thirdly, you require a qualified staff. For 5 beds, you need 1 nursing staff to be there, definitely. And we are in daycare, but you have to go for SSCO, under SSCO for pre-entry level, because it is a matter of cost. Because full NABH, is a little troublesome for initial persons. So we can start with the initial pre-entry, and along with that, we start preparing for the full NABH. Second thing is the cost. The cost for 5 beds, which charged by the NABH as a fee, is 25,000 roughly, and which has now been modified as per the beds, so increased. And in full NABH, it is yearly fee you have to pay, and you have to submit your data 3 monthly to the NABH. And they come for 2 assessments, one of informed, one uninformed, every year. And anytime they find any discrepancy, it can be withheld the certificate. So cost is more. Then you require 2 qualified staff of quality persons who can regularly conduct the data, the audits as required for full NABH. So if you are having free hand of the finances, you can go to full NABH from the beginning. But it requires 2 assessments happens. So 6 months
I
to
want to ask one question.
1 year or 1.5 years is required for final completing. So to go for pre-entry is better, that you get a certificate early in 6 months' time. But that too, after start of your hospital, 6 months data is required to be submitted with that. Okay? And it depends on you that if you are qualified, you have got enough time to conduct your own things, you can be doing it by itself. Or you can hire a person for particular work, some amount of work, or full NABH work. But ultimately, one person from your hospital is required as a coordinator. Even external agency may come, but they guide you out. And then when you start from beginning, you have to put the files. So roughly, in one case of eye, cataract or glaucoma, we got 23 to 25 pages file. And initially, when I started with this journey, I was also very, what is this all? But ultimately, when one of the hospital faced a problem of multiple cases of endophthalmitis and checked up by government, the only plus point was that NABH was started and they have got implemented the data. So they have got everything written down. Because after 3 years, if anybody files a case on you, there's nobody to answer. The doctor may not be there in the hospital. So the data is the only thing which help you out. So be careful always that time required to complete it. Because major things are tick marking.
Time over ho gaya na?
You create the data, the file, like such major things are tick marking. But if you complete the files, it will really help you in future. Any other question?
Thank you, sir. Sir, I just wanted to ask, should we hire a NABH consultant if we want to go ahead with this, or we can do it without
Because
it?
it depends. You are solo practitioner, suppose. And you have got much work to do. Then definitely you require somebody to help you out. Because he will come, guide on the day particular, ask something from you, you will give it, and the things go. So consultant is required in that case. And even consultants who are working, even me, we are not authorized at NABH as a consultant. Because it requires a multiple thing to be done, LLP, LLB and all. So anyway, many are working in MBAs and those persons who worked in hospital. You can have one of them because he also help you out in the आपके medical claims में. That person can be also trained along with the medical person and then your counseling of patient.
Thank you,
Because
sir.
if you are multi-specialty hospital, you can hire one person who can be authorized for this. That is depend on your workforce you have got. And initially when you apply, the employ your staff, be them multitasker. Nursing staff hai, get him learn the A scanning or other work, tension, taking something, hai na? So they will be only multitasker. Initially, kabhi bhi, we think we have separate person for it. It is not possible.
Thank you, sir.
Very rarely, some have got very good financial background to start with, so they can go out. But ultimately, we grow from slowly, and then, thank you.
Thank you, sir. Now I request Dr. Nilesh Kumar to join for the next talk. He's going to present on value-added services in low-profit private practice.
Thank you, ma'am.
Can we have his talk
Yeah.
uploaded? Dr. Nilesh Kumar. I request Dr. Sheffi to join us on the moderation desk, please.
Thank you so much, AIO Scientific Committee, for this opportunity. I am Dr. Nilesh Kumar, and I am going to talk about value-added services in low-profit setup. So these are my financial disclosures. So what is a value-added services? Let's start with that first. So you have your OPD services, that is the core of your hospital, and then you have an IPD services. So these is what patient pay for, directly pay for. They pay for your consultation fee, that is the OPD service that you're providing. You are doing an OCT, that is an OPD service you are providing. Similarly, they are paying for cataract surgery, retina surgery, that is the surgery, the service they are providing. But if what you do, if you hire a call center to book their appointment, they are not paying for that. So it's a value-added services. You are adding value to the service that you are providing. So it can be in-house value-added service, or it can be also outside the hospital, that is was for patient experience, like what we do as patient education on social media, making YouTube videos, and creating awareness, something like that. So now, how to decide which VAS is for you? So there are services that patient needs. And then there are services that you want to offer. There are endless number of services. You visit any hospital, you see, and you want to offer that service to your patient. But probably they might not improve your turnover. You provide that service and it's not helping you. So if there is an intersection in between where the patient, what patient needs, what you want to offer, and if it is improving turnover, that is the VAS that you should think about and start implementing in your practice. So let's discuss some bottleneck and pain points that I faced during my initial days when I joined my father's practice. So there was a very haphazard appointment system at my place. Billings and accounts were out of place. Health record was not kept at all. The OPD workflow was messed because if some patients started shouting, they were taken first. So ultimately, by the end of the day, almost all the patients in waiting area started shouting because they saw that it is getting them earlier. Then investigations and reporting, again, it was very immeticulous. Then IPD workflow was quite meticulous, but still the records were not there, discharge and follow-up. And then inventory management was totally out of place because everything was managed by some staff. So what I started with is VASIN appointment system. So once I joined, I created a website because patients had a waiting time of 2.5 months. And when they had to come to the hospital, get an appointment, go back and remember that after 2 months they have an appointment. And they traveled all the way from 200 kilometers, 300 kilometers just to get an appointment. So when I created a website, they can do it by their home. They can choose their slot. They have to come at 11 o'clock, 12 o'clock. Whenever they want, they can come. Similarly, after 3 or 4 months, I started a call center. A call center is an outsourced one where it is a 24-hour 1800 number. What they do is they book the appointment online. So anybody can call and book an appointment at their preferred time and slot. Just a day before the OPD appointment, they get a reminder call that you have an appointment. So even if it is 2 days or 3 days or 1 week, they tend to forget that there is an appointment. So they get a call and they are told at that time that please be on time. This is your time. Don't come before it. Don't come after it. And please bring only one attendant with yourself. So earlier, with each patient, there were 2-3 attendants. Now with constant reminder, that has come down, and we have around, the average is around 1.5 right now. And then they also call about follow-ups. So if I remember a patient that had a complication and he has not come for follow-up, I just ask the call center to give a call, and they come. Similarly, what I did is a value-added service in OPD workflow. So right now, what you see are unit economics of meticulous examination. If you want to do, you do an ARNCT, then they go to optometrist, then a primary examination is done by a consultant, then the patient gets dilated, then cataract and fundus evaluation. And if glaucoma or anything else has to be done, they have to come for other visit. If OCT has to be done, they wait for OCT angio, and then they come back again to consultant, and at that time they are dilated fully. They don't understand what you are showing them on OCT, and they probably will come again next day to again understand and then get the treatment done. An alternative workflow, what everybody does nowadays is the optometrists themselves dilate, so you save 1 hour of waiting time. But again, the problem is you miss on pupillary evaluation, and NCT, if you have to do applanation again, you have to call them another day. So both of them, the waiting time, total waiting time is around 4 to 5 hours, and this was displayed in Singapore Eye Hospital, that you have to wait for 5 hours if you want to get a complete examination. So Singapore, the most premium eye institute of the world, has to do that. Can we do something differently? So what I did is, this all I told. So what I did is, I asked my patient to get a Claris imaging done. It's a 75 lakh instrument, but all of my patients get it for free. Autoref NCT, a Claris image, go to optometrist, come to me, almost a 200-degree view of fundus. So if it is normal, I don't have to dilate them at all. If there is a pathology, they understand that, okay, this is a microaneurysm, this is a hemorrhage that is there, this is a neovascular membrane that is there. And within 30 minutes, the patient is in and out if there is normal routine refraction or something. If the patient is having cataract, if they are high myop, they definitely get dilate. We don't. If they are complaining of floaters, flashes, definitely we don't compromise on dilatation at that time. So what it has done around is a faster turnaround time, more happy patients. The patients who are premium, like doctors, lawyers, judges, bankers, they are now coming to our hospital because they don't need to get dilated for their annual diabetic checkup. Then dilated has come down to 25% from 100%. All of our patients were getting a dilated fundus examination when I had joined. So it has, like you can say, a surrogate way, they have increased patient flow and revenue turnover. Similarly, in VASIN follow-up. So everybody calls a patient for 1 week follow-up. And what we do, we see that they are seeing clearly or not. And then we tell them, okay, you start your head bath or whatever precaution that you want to tell. We can do that same by calling. You call up the patient, my call center calls up the patient, ask them how are you doing, everything is fine, no complaint, please start taking bath. Any complaint, please come. Now, 100% of the cataract patients that were visiting us at 1 week, they are now visiting directly at 1 month, and we are not losing. If they are complaining, we tell them that please come. They also feel a personal touch that, okay, doctor is concerned with me. His office has called and told me to take bath. They take bath. So what it has done is enhance the patient experience and also freed up my OPD time. I can see fresh patient in that time and increase the turnover. So that's how you build. Any value-added services, is it increasing your turnover? If it is increasing your turnover, it's worth investing in that. So that call center I am spending around 50,000 for that, just for the call center, and then there are certain added expenses on that. But it is generating me around 1.5 lakh of revenue in this indirect method. So with that, I'll end my talk. Thank you.
Very interesting talk. I think so you have invested a lot to increase so how much is has it increased the turnover in your?
Yeah, so right now we are, when I had joined my father's practice, my father was seeing around 35 patients OPD because he wanted it to be limited. Was working very limited hours, but his full potential was to see around 45, 50 patients. Now with, I have joined, and our surgical load has increased twice. Like I am operating around 18 to 20 patients per day. In spite of that, we are seeing around 100 to 110 OPD.
How did you increase your footfall? That's what I would ask.
So once the patient is like, when we are
mouth to mouth practice?
Mouth to mouth practice, yeah, we have not had.
Digital
my
marketing
father's
or
practice, the waiting period was like the patients were waiting for 2.5 months to get an appointment with him.
Okay.
That was not a problem to get the patient. The problem was their experience was not that good because they had to wait for so long.
So you
that
invested on patient satisfaction.
Yeah.
Any questions from the audience? Thank you, Dr. Nilesh.
Thank you.
Thank you, Dr. Nilesh. Our next speaker is Dr. Tanya. She'll be talking on case-based panel, when to trust or override AI in ophthalmic practice.
Thank you, Dr. Shafi. So my topic is an extension of what Dr. Nilesh had just said, when to trust or override AI in ophthalmology case-based panel. So we all know that AI is here to stay, and it is going to improve the services. Some say it will take over healthcare one day, but I don't think so. AI is there to stay. I would say 20% of our work can be done by AI, but it won't 100% replace us. But at 20% work, it will do 1,000 times better than what we are doing. So I would say use it as a tool to improve your services. As Dr. Nilesh said that he's using Claris to see whether the screening of diabetes and other fundus images for those purposes. But can you trust it 100%? So AI is being used in different fields in ophthalmology, subspecialties. In retina, it is being used for diagnostic and screening purposes. IDX-DR is first FDA-approved autonomous DR detection system. iArt is used for DR screening, ret marker for diabetes retinopathy progression prediction. Google DeepMind is used for OCT for AMD, diabetic retinopathy and edema. Wide field fundus telescreening is also being done in certain parts of India, but mainly in Thailand. Glaucoma, multimodal AI is being used for OCT plus visual field plus IOP history. Predictive modeling for conversion risk is also being seen by this thing. Cornea, and if you remember the perimetry itself, the CETA, it is also an AI only because it is predicting and analyzing whatever data is being stored, and then progression is also seen by that. Cornea and refractive, we are using AI for AI-assisted keratoconus detection, early ectasia prediction, AI-guided IOL formulas. It's going to overtake whatever formulas we were using till date. Refractive surgery candidate screening with AI. In anterior segment and cataract, slit lamp images, AI for cataract grading. Recently, I was assessing certain papers, and in those, many of them have used these models. There are many models available in the App Store itself right now, where you can go in camps and assess the cataract using the AI in undilated cases only. So you can send anyone in the field who can assess the cataract and show it to the patient, and the patient can return back. AI in surgical video guidance, it is being used for capsulorhexis, phacoenergy, we all know now it is being used. Then machine learning IOL formulas, they are outperforming all the regression methods. Oculoplastics, AI is used for orbital eyelid tumor image analysis. Computer vision for ptosis and facial nerve palsy quantification. Then AI is also used for detection of dyspallor papilledema versus pseudopapilledema. Teleophthalmology, we all know in COVID we went for teleophthalmology. I also registered in Dr. Liberate and many patients we got, but we were not able to see the images. So whether the patient should be coming to the OPD or to ophthal or not. So then chatbots came in and that they are being used for triage now, whether it is an emergency or routine. Community DR and AMD trainee screening programs are going on. Integration with smartphone fundus cameras is an important addition. So now, whether to trust AI generated images or not, that's the question. So this is one of the images which is shown by IDX DR. In this, you can see that there are certain images, whether these images can be trusted, but whatever it is giving, whether this report can be trusted or not. Just by uploading the image, can we get a clinical decision? Yes, in this case we can, because the image is clear, the AI confidence interval is 95, more than 95%. That's why when it says that the patient is having mild diabetic retinopathy, the patient can come back in 12 months and again get his fundus checked. So we give the decision then and there and trust AI in this case. Here, as Dr. Nilesh said, in an undilated fundus, we can give that image and it is more time saving. So it will improve your practice. Then there's eye art image. Again, a similar case, the image is good, so the answer is good. The 95% AI confidence interval can give you that kind of a confidence in you also, just trusting the image, just trusting whatever clinical decision is made by AI, you can trust and give your answer. But what happens if this is the case? So, AI is all based on what image we are uploading. So in this case, when there is high-grade cataract, but still the human eye can see what is happening inside the fundus, but not the camera. Camera sometimes cannot capture what we are. Still the cameras are evolving, but our human eye, it can see through the hazy fundus also. So in this case, even if it says that the patient is, the AI will tell that you need to repeat it, but still it will say that it has no diabetic retinopathy, the patient can come in 12 months, but please correlate clinically. So in this case, you need to trust your instinct rather than the AI. So the confidence interval, which is mentioned on the screen itself of the AI, is important. Then OCT in wet AMD. So in wet age-related macular degeneration, we get an OCT image. If the image is good, the media is not hazy, again, you can trust the AI. You can see in this image, there is a lot of subretinal fluid and the image is very clear. It is also quantifying what amount of subretinal fluid is there. So if it is quantifying and the AI interval is good, you can trust and make a clinical decision accordingly. In ROP screening also, so NICU, we all know many of us are not trained in ROP screening. So this is a very big breakthrough which is coming, iROP. It's not yet available in India market, in our North India at least. So NICU wild field images, AI flags plus disease, AI output, positive detection, sensitivity optimized algorithm. So trust it. Validated models are available for high sensitivity for ROP. The sensitivity is very good, but specificity is not yet. But it is good to err on the safer side. So if the iROP is saying it is plus disease, refer the patient to a VR center so that further recommendations are made and treatment is done. Glaucoma visual field progression. So stable glaucoma, AI predicts whether the visual field decline is there or not. So this can be completely trusted because reversed when visual field reliable plus OCT retinal fiber layer thinning is concordant with it, then you can go ahead with this because it combines three things. It is combining the OCT image, the visual field, and the IOP history. So that helps. So IOL power formulas also, the ones which are coming up with AI are much more robust than what we have as regression models. Especially in the eyes with high myop, post-LASIK, these IOL calculating formulas are working much better. Now this case, corneal topography with ectasia. So AI computed corneal tomography predicted that this patient is of keratoconus. But when you saw it clinically, you find it, no, it is not. Here, you can override it. In triage what also, it is much more important to err on the safer side. So if it is saying that it requires a specialist, then we have to trust its decision. So what I would suggest is device validation matches patient and setting. So whatever device has been tested, it is tested in certain settings, whether the patient, what demographics they have chosen, whether it is Indian population or not. It is mostly it is made in Chinese population these days, whatever AI we are getting. So we have to test it in our settings, and then only we have to give our clinical decisions. Also the people who are making those decisions, they are actually quantifying it for what a clinical specialist over there is saying for that data. So that kind of error can be there. So you have to correlate it clinically. Then image and data quality flags. If they are green, then you can go ahead with it. AI confidence. So the confidence interval, we have all read statistics. So more than 90% plus explainable, then we can trust that AI. Functional plus structural plus clinical science concordant is important. Patient context should align with AI assumptions. But again, medico-legally, we are not safe if we say that our machine said that this is this wasn't diabetic retinopathy, but the patient turns out to be diabetic retinopathy and the eye gets destroyed later on. So you are not able to abdicate your duties as a clinical decision maker. You can only augment it with AI. Thank you.
Very nicely said. Actually, it should be used only as a screening tool, especially in peripheries where the doctors or experienced doctors cannot go. But in medical legal cases, as you have said, it cannot match what clinical experience we have and to the AI.
It can only help, not actually remove you
True,
from the equation.
true.
Thank you. Any questions?
Thank you, Dr. Tanya. Any questions from the audience? Okay. Our next speaker is Dr. Devanshu Arora. No. Dr. Pawan Puneet. Okay. So Dr. Pawan Puneet will be speaking on blind cases deserve an extra effort with diligence and perseverance to hope for the rays of light.
So, a very good noon to all of you. These cases are those cases which even taught us the lesson, and each case carries a story in it. So, these are cases where we give an extra effort, try to put someone when the patients have been refused from various center, with the thought that, as Roosevelt said, at the end of your rope, tie a knot and hold on. So the first case was a scenario where it was which taught us a team approach, and thanks to cornea team. Within a week time, the case progressed from here to here, was referred from outside. So you can see this, and gram-positive cocci along with the hyphae plenty. We didn't have the graft available at that time, so we referred to our colleague, one of our friends, Dr. Ashok Sharma sir. He was senior in PJ also. So he did the nice graft for us, and post-keratoplast, the patient was referred back for further management. And these are the magenta-colored fungal hyphae, and these are, when they are right-angled, they show you that it's aspergillus basically. So this is a surgical scenario there. Volume nahi aa raha hai. So just remove the graft, these exudates from there, and the posterior exudates were also removed. They were plastered on the iris surface. So they were, at times, with the bimanual also, you have to take these exudates in your hand and cut with the help of the cutter. Volume nahi aa raha, boss. तीनों ने हेडफोन लगा के बैठे हैं, वॉल्यूम उनको भी नहीं सुनाई दे रहा कि क्या कह रहे हैं. चलो, so the exudates were cleared. You can see we got a good retina thereafter, and so post SOR we had a nice retina, and the patient has gained a vision of 6/12, and it's a joint team effort. With at times you have to approach out of your center also when they have a graft, so that you can have do something good for the patient. Second scenario was a very sad story of a banker, 35 years old, who got a injury in one eye in the childhood and presented to us with the injury in the other eye.
Like in the only seeing eye of
This was
this
a
young
banker.
banker with zone 3 injury for more than 180 degree under the recti.
So just like a ruptured
After
orange you had.
approximation with primary repair, there was with hemorrhage as well as retinal detachment, making the
RD with the
PVD
vitreous
induction
hemorrhage is always a
difficult.
nightmare.
So, after making an opening in the posterior hyaloid, PFCL instilled to aid in PVD induction, followed by extraction of subretinal blood with the cutter. Even PFCL and fluid was leaking out through the rupture site, so a temporary tamponade with PFCL was given. The patient was advised strict supine position, and after 2 weeks, second surgery was done to complete the surgery.
So it's a two-step procedure basically.
PFCL oil exchange along with 360-degree retinal laser and silicone oil retention suture was performed. Happy to see post-SOR patient navigating himself with the aid of FAQ classes.
And the third scenario, you at times, thank you Ayushman Bharat scheme. Otherwise, they generally tax us so much that we cannot earn from them. But in some of the scenarios, you really want to thank you. This was a case of a lady, one-eyed lady who had got around 16, 17 injections, 84 years old, unable to accompany from a village, and आके कह रहे हैं कि मैं इंजेक्शंस नहीं लगा सकती, अब मुझे ब्लीडिंग हो गई है, किसी ने कहा कि इसमें अब दिस इज गॉन आई. So in that eye, what we opted
Complex
for,
and massive subretinal bleed was planned for autologous choroid graft, subretinal fluid injection and partial pegs done, followed by cautery and RR for more than 180 degrees. This was followed by folding of retina on itself, and whole blood and CNVM complex was taken away with the cutter. Thereafter, RP choroid was harvested and transferred under the PFCL, followed by retinal laser and PFCL oil exchange done. Post-op, we can see nicely placed graft and patient gained a vision of pointer finger 1 feet. Another
patient gained a good vision of at least 1 feet and is now got rid of any sort of injections for the lifetime. And the cardiac patient, poor patient who do not have someone to accompany even to pay for the injection, this can be taken as one of the options. In the another scenario, there was a 5 perforation in a single eye of the patient, high myope.
high myope. After AC wash with me, some subretinal blood seen oozing was
Recent shaved
trimmed.
macular hole you can see there.
Followed by PFCL installation. Island plugs and flaps were used to fill the crescent-like crater.
There's no other way we could have plugged
Base
up this
section
macular hole.
done. Holes, lattices were lasered along with application of
The
3
entry hole
rows
was there
of laser.
the injection.
PFCL oil exchange performed. We can see at monthly follow-ups well attached retina and closed holes. Another case.
So coming to the scenario where I believe that aphakia should be considered as the best option. And these are one-eyed patients of non-approachable cataracts, black brown cataract in a case of rheumatoid arthritis, I will just be showing, and a 6 mm cornea with a black brown cataract was refused surgery from the 2 senior experienced cataract surgeons of our center also.
The patient could not see because of 6 mm microcornea. Coloboma and hard brown cataract was managed by securing a 6 mm infusion cannula along with chandelier and inducing inverse couching, followed by clearing the vitreous and phaco-fragmentation. Nice to see patient well adapted to her environment.
वो ये पेशेंट सर्जरी करा के अपने गांव चला गया, वहाँ से फोटो मंगवाई है इनकी. They didn't turn up even for the follow-up even. So thank you. These were the cases where we try to put an extra effort to just to have teach something to the patient. Thank you.
Very nice cases.
Thank you.
And we should make an effort to actually preserve the blind people with good vision. Yes. And thank you, sir.
Thank you.
We have the next speaker, Dr. Himanshu Khandelwal. Okay, then we conclude this session. Thank you, everyone. All the speakers who are present in the audience to come in for a group picture.